Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Abbara, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Abbara. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Welcome to today's kickoff episode for the podcast. We were recording on Friday, April 17th, 2020. Our topic today is, well, it's an esoteric, out of fashion, really not frequently discussed idea. I'm totally kidding. Of course, we are going to be talking about COVID-19. It's all the rage these days. The focus of today's episode is the recently published RSNA expert consensus statement on reporting chest CT findings related to COVID-19. This statement was written by expert thoracic radiologists from institutions across the United States. It aims to achieve two major goals. Number one, help imagers out there know what COVID looks like on CT. And number two, provide a structured reporting template to communicate COVID-related findings effectively. The document was published on March 25th, 2020, and is available open access online on the Radiology Cardiothoracic Imaging Journal's website. On this episode, we're going to chat with the journal's editor-in-chief, Dr. Sunny Abbara, the statement's co-first authors, Dr. Scott Simpson and Dr. Fernando Kay, and senior author, Dr. Harold Litt. First, let's bring on the journal's editor-in-chief, Dr. Sunny Abbara. Dr. Abbara, how are you doing, and how have things been going in the COVID pandemic setting?
Thank you, Praveen. I'm doing very well, thank you. And I'm keeping very busy, as so many of us. I am, of course, involved in the reporting and management of cardiac and chest CT and X-ray studies in COVID-19 patients and in others. And as so many folks, radiologists around the country, we are involved with a lot of planning meetings, creating flow charts and emergency management systems that we all have to do in response to the COVID-19 pandemic. These can keep you busy. And on a different level, as the editor-in-chief of Radiology Cardiothoracic Imaging, I'm, of course, as you can imagine, very busy handling our usual flow of manuscript, but now also a large number of manuscripts that relate to COVID-19 in order to have high-quality, curated content come out in an unprecedented, fast manners. We have created a task force that has been doing a really tremendous effort in getting these manuscripts published in a really fast turnaround time. And I think this is particularly important in the context of the mission of our journal. Our mission is to improve health outcomes through dissemination of science, of education, and innovations in the field of cardiothoracic and vascular imaging. And I feel this is never more true than now during this time, where we can have a real effect on healthcare through what we're publishing through this journal.
Excellent. Well, welcome on to the RCTI podcast. I really appreciate having your time here. Let's dive into the RSNA expert consensus document itself. Could you talk about why this expert consensus document was needed?
Yeah, so as I mentioned, we are in a pandemic right now. So we're all faced with new questions and challenges. And for me locally, the challenges were there. How do you report certain findings that you see? Overutilization of the word COVID-19 alone in reports triggered the concern that we may unnecessarily be burning PPE and having people furloughed if we're too frequently using that term in our reports. We did not want to do the opposite either and have somebody who potentially has the disease go unrecognized because we're too shy in using, trigger words. So we have locally engaged in conversations with our our stakeholders, the chief medical officers, infection prevention team, and our emergency room leaders. So as we're all across the nation or the world really engaging in these conversations, the journal was receiving a number of articles, and some of which were sharing their local experience and what reporting standard they would have come up with, interest of standardizing reporting and therefore improving operations for that health system. And one person called me up, and that was the senior author of the guideline, Dr. Litt, who was interested in publishing their established system. And we had a good discussion. I had to tell him that, unfortunately, I felt that it was not right to publish this because we've been receiving at the time multiple somewhat discrepant systems that people had developed. And I felt strongly that it was time to develop a national guiding document, an expert consensus statement that would include the aspects that all of these local systems have brought forth in a document that can be used as a guide to those that are in the various stages of developing their own local reporting standards. So that was the origin of that. We have then created a writing group. We were very happy to have RSNA's support, who ultimately was an endorsing organization or sponsoring organization. And we ensured to be in keeping with the then existing documents from the Society of Thoracic Radiology and the American College of Radiology that were not about reporting, that defined the role of imaging in the context of COVID-19. And so we were in keeping with those statements, and we were fortunate to receive endorsement by both organizations, the STR and the ACR, of those guidelines.
Excellent. I noticed that those major societies that have endorsed this document are also the same that have suggested not using thoracic imaging in the diagnosis of COVID. Could you speak more about the relationship between this document and those other recommendations?
Yes, so thank you for that. The timeline here is that the Society for Thoracic Radiology at their annual meeting had a special session, and during that special session they announced or immediately after a statement from the STR that essentially said that there isn't a role for CT imaging in particular or imaging for screening for COVID-19. Soon thereafter, the American College of Radiology came out with a statement that was concordant. It had a few additional pieces of information in it, but that also identified imaging not as a screening test. They talk a bit more about what the role is of imaging in COVID-19. But both statements clearly identified imaging to not be a screening test that could replace PCR testing.
Perfect. Thank you very much, Dr. Abbara. It's really great to have this perspective on how the document was born and how this document works with all of the other recommendations that are out there. I really appreciate your time, and thank you for joining us.
Okay, thank you, Praveen.
All right, let's get into the nitty-gritty of the expert consensus document itself. I'd like to introduce co-first authors, Dr. Scott Simpson from the University of Pennsylvania and Dr. Fernando Kaye from the University of Texas Southwestern. How are y'all doing?
Good. Happy to be here. Thanks for having us.
Hey, good. Thank you.
Of course, thank you all. Thank you and welcome to the podcast. First, let's start by briefly reviewing how the expert consensus document breaks down those typical and atypical findings of COVID on CT. Dr. Simpson, could you kind of help us out with that?
Yeah, definitely. We decided to divide CT findings into 4 categories: typical, indeterminate, atypical, and a negative CT. The rationale for the typical features were those findings that were commonly seen in the setting of COVID-19, but were felt to be of relatively greater specificity. And the CT findings that we saw here were findings of peripheral opacities or rounded opacities, usually of ground glass attenuation, so with or without intermixed consolidation or crazy paving. The indeterminate category, these were features that were also commonly seen in the setting of COVID-19, though felt to be of lower specificity. Here we really were talking about ground glass opacities, again, with or without consolidation or crazy paving, so without a clear distribution, or if you saw a couple tiny ground glass opacities. The last category was atypical. These were features that were either not reported in the literature or very infrequently reported in the literature in the setting of COVID-19 on CT. So things like, isolated segmental or lobar consolidation without ground glass, tree and bud opacities, central aguilar nodules, a typical bronchiolytic pattern. These are not characteristic of COVID-19. Smooth septal thickening. So features that were not reported for COVID-19 that could be seen with other acute lung diseases. This is the category for atypical. And then the last category would be negative. Negative is pretty self-explanatory. There's no features that would otherwise suggest the presence of pneumonia on CT.
Great. And I understand that these 4 categories of imaging findings align with the standardized reporting scheme that's suggested in the document, correct?
That's correct, yeah. So the standardized reporting language is in the last column on the table that's in the consensus statement. And so the language didn't really focus on specificity. It didn't really talk about likelihood or suspicion. It really just focused on what was reported in the literature. So for instance, for typical appearance, what we said were commonly reported imaging features of COVID-19 pneumonia are present. However, other processes such as influenza pneumonia and organizing pneumonia can be seen with this imaging appearance. And the idea was to give people or readers a sense that yes, these features are seen with COVID-19. Yes, they are fairly more specific, but no, they're not pathognomonic, that you could see these in other disease processes. And this is kind of reiterated throughout the additional categories. So indeterminate, we just said that the features can be seen with COVID-19, however, very non-specific and can be seen in a variety of processes. And then the atypical, again, we just kind of commented what was on the literature, that these features are atypical or uncommonly reported for COVID-19 and then left it at that.
Nice. And when it comes to that sensitivity and specificity, have there been any validation studies for this consensus statement or just for CT findings in general for COVID?
Yeah, so it's interesting. We did the best that we could with the literature that was available. And there was obviously, definitely some flaws with the literature that was out there regarding sensitivities and specificities. So regarding the sensitivities, the papers that did come out that talked about sensitivity, some of them reported a very high sensitivity, but there were flaws in those papers. They didn't really talk about what was considered to be a positive value on CT. Was it just a little bit of ground glass? Was it tree and bud opacities? They didn't also specify when the CTs were performed with respect to patient symptom onset. Was it done a week after, 2 weeks after? So they didn't really define the cohort that well. And then they also didn't really specify what viral swab or viral test that they were actually using in those studies. So it's kind of hard to know how CT compares to that of viral testing. And then in addition, there's been some other studies that reported lower sensitivities, right? So the Princess cruise ship, the sensitivities there were only about 80% in people with symptoms and 60% in people without symptoms. So again, it's pretty variable. And also the sensitivity of CT really depends on time of onset. So during the first 2 days, the CTs are typically negative. And so there was definitely some flaws in the study regarding the high sensitivity. The specificity, on the other hand, there's not really any literature out there so much. There's the one paper by Bay and colleagues that looked at comparing, the appearance of COVID-19 pneumonia to that of other viruses. But the problem with that is that it was only comparing it to other viruses. In order to assess specificity, you really need to get a representative cohort of patients that are truly negative for COVID-19. It's, true negative over true negative plus false positive. And, that really hasn't been looked at. We are starting a study at Penn right now. We're just kind of taking a cohort of patients that don't have COVID-19 and then applying this RSNA consensus criteria. This criteria yet hasn't been studied to determine whether or not it's how truly effective it actually is. And so we don't really know. So it definitely needs to be studied going forward.
Nice.
Yeah, that's an excellent point. We developed that as our best approximation of reality is by looking at the available literature on COVID-19 patients that was mainly published from Chinese studies. And now with the pandemic and we are trying to figure out if these findings, they are also validated in other cohorts. So we have some papers coming out. There's a Iranian group publishing a case series of about 100 patients in radiology, cardiothoracic imaging, which basically confirms everything we put in the statement, which is the typical and atypical findings. So that's reassuring. We have a good data showing that the disease behaves from the imaging standpoint similarly to what the Chinese studies already showed. And in addition to that, as Scott had pointed out, many institutions are now studying how that system, the RSNA consensus, behaves in a real life scenario. And that will be important. And I think that from some preliminary data that I have the opportunity to review, the typical and atypical, especially the atypical category, is helpful in guiding clinicians towards other diagnoses other than COVID-19.
Awesome. I think that these validation studies are going to be super helpful, but it's probably important to know that in the middle of a pandemic, knowing the real prevalence and therefore the predictive values of these studies is going to be pretty limited. When the COVID disease was kind of first rising in the United States, all of our initial radiology reports danced around using that COVID word as to not cause a panic. It felt like we were using the virus who must not be named, kind of like Voldemort from Harry Potter. In what clinical scenario do y'all think this consensus statement should be used? Is this prior to a diagnosis of COVID, after a diagnosis of COVID?
Yeah, so I think it was really intended for people that were being worked up for COVID-19 before a diagnosis of COVID-19 was actually made by a viral swab, or in somebody that had a negative viral test and then had imaging findings that were potentially attributable to COVID-19. As the disease progresses, and the diagnoses have already been established, the imaging findings for COVID-19 will change. And so that the initial presentation of peripheral ground glass opacities, which is typical for COVID-19, may evolve into a pattern more suggestive of diffuse alveolar damage with diffuse consolidation and ground glass opacity that would technically be indeterminate for it. And so once the diagnosis of COVID-19 has already been established, follow-up imaging, it's probably unnecessary to use this RSNA consensus terminology for follow-up imaging once the diagnosis has been established.
Is there a method for radiologists to easily gather that information about COVID diagnoses, or is it more just searching the electronic medical record to see what the diagnosis is?
So we did establish in the RSNA consensus document unique coding identifiers. So at Penn, we have a system called Montage, which you could use to search reports and pull out wording from reports. And so by introducing these codes to the standardized language, you could easily find which reports you've reported out as being typical, indeterminate, or atypical, and then looking to see, which of those patients had tested positive and what the outcomes actually were. We also have, a pretty big informatics program. And so we've established a COVID-19 dashboard on Epic, where we have all the patients, listed that have COVID-19, what kind of imaging they actually have. And so it is easy. We've made it as easy as possible to kind of track what's happening with these COVID-19 patients, particularly with their imaging.
Yeah, we don't have that capability yet. I mean, we do use the templates here at UT, but I think that at some point we'll be analyzing, but not in real time as they are doing at Penn.
So, I think it's very institutionally based. So at Penn, the clinicians, will specifically put in their indications assessed for COVID-19. And so it's already in the patient's chart, it's already in their notes that they're being worked up for COVID-19. And so we feel a lot less hesitant to use the word COVID-19, especially in those clinical scenarios, just because they already are under suspicion, they're under investigation for having COVID-19. I think the problem really comes up when it's an incidentally discovered finding that's potentially related to COVID-19. And these scenarios, we did put some language into the consensus statement as to what to do with that. What I've been doing and what I think a lot of my colleagues have been doing is really just reaching out to that clinician, letting them know that there are typical features of COVID-19, and then having a discussion with them about whether or not they want to mention COVID-19 in their report. Most of the time, they're okay with us, mentioning it because, they're going to talk to the patient and then make that assessment. Sometimes, if the patient just started a recent immunotherapy or something like that for lung cancer, they may not want us to put that in the report because they may feel that it's more likely to be related to that immunotherapy. So I think that it gets a little bit murky with the incidentally discovered typical features. But when patients are under investigation, there's really not much hesitation to use the word COVID-19 in the report just because they're already being worked up for it.
Yeah, in our institution, we faced the pandemic probably at a different time point as they did in the northeastern part of the U.S. Our numbers it took probably a couple of weeks to catch up with the numbers in the Northeast. So our clinicians were particularly worried when we first start mentioning COVID-19 in the reports about the implications, especially because we did not have our PCR testing capabilities up to speed at that point. And they felt that using the word COVID-19 were like boxing them into a management route that it might eventually lead to ramifications where they would be obliged to do testing people who they did not think were actually COVID-19 patients. So that was a challenge at the beginning, but I think that now with the testing capabilities up to speed and especially with the widely diffuse community spread that we are seeing here within our community, they are less preoccupied about having the word COVID-19 in the reports. And actually they asked us now to implement in the chest radiograph reports some wording that conveys them like a probability of those findings being related to COVID-19, and specifically using the word COVID-19 seems not to be a problem at this moment. So that's changing.
With regards to those chest x-rays, I know that the RSNA expert consensus document focuses on CT. Has there anything been published, or is there anything that's brewing about standardized reporting for chest x-rays?
So I can, in regard to this, I can only really speak to what's happening at Penn. So there's a consensus group of what to do with COVID-19 imaging findings at Penn. We have developed standardized reporting language for the reporting of chest x-ray abnormalities that we're instructing residents and non-chest imagers to use when interpreting chest x-rays specifically for people under investigation. That really kind of, again, focuses on what's been reported in the literature, that is, bilateral multifocal opacities, unilateral opacities, which we think convey probably a lesser likelihood of probability for COVID-19, and then a pattern of like lobar pneumonia, which would obviously mean that it's probably less likely to represent COVID-19, and then areas of cavitation. And so we did implement some structured reporting for patients under investigation.
Yeah, same thing here. We've been developing standardized reporting for chest x-rays, and that's helpful for clinicians in their process of defining which patients need to be tested urgently versus the ones that can be tested in an outpatient basis. So that's something that we've been developing without any RSNA supported guidance. And I think that one of the main challenges to implement such reporting standards for x-rays is the limited availability of papers, specifically looking at x-ray findings and the naturally less specific aspect of the x-ray findings. So I think that that's the main challenge of having that. And we have received a paper which is specifically focused on the pediatric population, where they are proposing a system for reporting CTs, which is based on our RSNA consensus, and a similar system for chest x-rays. So especially for the pediatric population, where CT is probably not, is definitely not the first imaging tool, there might be a document that at least provides some guidance for radiologists dealing with the pediatric population.
Great. It sounds like the overall narrative over the past several decades now for standardized reporting in radiology has been favorable, but I kind of want to get your perspective on the pros and cons of standardized reporting altogether and in the context of COVID.
Yeah, so I'm generally in favor of standardized reporting language. What I like most about it is that it's kind of easily studied, and so it limits what people are saying in reports. And if you limit what people can kind of say in reports, you can more easily data mine those reports to look for specific terminology. And then you can kind of learn from that and see how the terminology that we're using affects patient management, what's our accuracy regarding it. Some of the cons of that is you really got to get a lot of buy-in for it, and it's hard to get people to change what they're doing, especially because what they're doing is, not only based on anecdotal experience, but some of the literature that they've read. Specifically regarding COVID-19, I think the biggest con was, again, getting buy-in from people. I think that a lot of people didn't want to mention COVID-19 in their reports. And there was a lot of institutional variability as to how to report out COVID-19. And so I think that was the biggest drawback was, trying to get this, this swell of buy-in to actually use the consensus document. And then as, Fernando had pointed out, a lot of physicians really felt constrained by the language, but I think a lot of that is being kind of dissipated now.
Yeah, I agree. We've been facing the same challenges here. When you have we have more than 100 radiologists, and many of them are reading chest CTs, and also with the request that we provide standardized reporting on chest X-ray, so that number of reports with standardized templates have exploded. And as you can imagine, there's a wide spectrum of people who would easily think that this is a great idea, jump in, use that. Others, and I think that they have their reasons, they are more resistant to doing so. And I think that some of the resistance came anecdotally from sometimes you have cases that are not clearly typical or clearly atypical, where you have some gray zone, and radiologists, some of them will feel constrained, uncomfortable by going one direction or the other. And that's, I think that's some of the reasons why people don't like being boxed in standardized templates and prefer to use their subjective narrative of what they are seeing, what their impression is. But there are many advantages of using standardized reporting. And from a management standpoint, for the clinicians, it's really important that they have something that can provide an unambiguous statement of what that study is about.
What then do you think are the next steps for this consensus document? Are we going to just watch it evolve? Are there going to be additional components?
Yeah, I think probably the next step is just to see, how well this actually works and how it's actually impacting clinical care and how it's being integrated into clinical care pathways. Depending on what comes out, there certainly could be modifications to the language, maybe providing, more specific language in the report about positive predictive values in certain scenarios. So I do think that it is open to revision, and we did, make this document expecting, or at least anticipating that, based on it, that there may be revisions in the future.
Yeah, that's right. The consensus states this is a fluid and dynamic, as knowledge progresses and all these papers are coming out with different aspects, either confirming or sometimes providing some additional information about the aspects of COVID that consensus may be revised. One example is that there are at least a couple of papers published before the consensus which show that vascular enlargement was one feature that was highly prevalent in patients with COVID. We thought that there was some difficulty in determining what vascular enlargement means as a radiologic sign, because it has not been extensively explored before. We don't have a specific definition of that, but there might be something to look and investigate more deeply with more appropriate methodology, and to determine if that has any specificity at all, just as an example of how knowledge evolves and how that might impact the consensus in the future.
Excellent. Hey, I'd like to thank you both. Thank you, Dr. Simpson, and thank you, Dr. K, for helping form this document and for coming onto the podcast to chat. It's been very helpful and very interesting.
Great. Thank you for having us.
Thanks so much, Praveen. Thanks for having us.
Now, I'd like to bring on senior author Dr. Harold Litt from the University of Pennsylvania. Hi, Dr. Litt. Thanks for coming onto the podcast. How are things going?
Thanks, Praveen. Things are going pretty well. Here in Philadelphia, it's a sunny day, and it looks like our social distancing measures have been working, and we've only been seeing a very slow increase in the number of cases in the city and in our hospitals.
Great. That's optimistic, especially compared to what things were like just a few weeks ago.
That's true. We were making plans for a very dramatic surge in cases and modeling 3,000 or more chest x-rays per day in our hospital, bringing extra staff on to read those and redistributing people in the department. So we're cautiously optimistic that we won't have to enact any of those plans.
Yes, I totally agree. Dr. Litt, I'd like to start our conversation by asking you about the general accuracy of CT compared to now what most of the United States is using as its reference standard, PCR-based tests for diagnosing COVID.
Well, I think when you're talking about the accuracy of CT compared to PCR, there are a couple of different issues that you really have to think about. One is, when in the disease are you performing either of the tests, CT or PCR? And the other question is, exactly what technology are you using? So I think there's pretty good evidence that CT can be normal, or perhaps only minimally abnormal or non-specifically abnormal, early in coronavirus infection. We don't really know what the sensitivity is of CT, but we do know, I think, that there are a fair number of cases where the CT is negative early in the disease. Now, the question of accuracy of PCR is something that's maybe a little bit more controversial. And this depends, again, on when you're performing the test in the disease and also what technology you're using. Some of the initial reports of a low sensitivity of PCR, particularly early in the disease, were in studies where they were mostly using throat swabs. And we know that throat swabs are much less sensitive for detecting the coronavirus infection than nasopharyngeal swabs, and you may miss half of your positive cases. The other potential limitation was exactly which test was being done. The PCR tests, many of them were developed locally and may not have had good performance. It seems that most of the ones that are currently being used in the United States have a much better accuracy and better sensitivity, and certainly the ones that are approved by the FDA are, you were talking about accuracies and sensitivities of greater than 90%. So I think in trying to answer that specific question, you need to take these factors into account.
Has there been any work on validation of CT relative to PCR or in general?
Well, there were a couple of papers that were published by groups in China that were early in the experience, suggesting that CT was positive in a large number of cases in which PCR was negative early in the disease. There were two studies about this that most people are pointing to, and actually there was a review of this literature published just yesterday, April 16th, 2020 in AJR, so I can recommend that people take a look at that. But in both of these papers, they showed, or at least suggested, that in many patients who initially had a negative PCR, which sometime later in the course of their disease became positive, those patients had CT findings, and there was the one study which touted a CT sensitivity of 98% and a PCR sensitivity in the 70% range. I think when we look at that kind of data, we have to recognize some limitations of those studies. You know, first of all, we don't really know very much about the patient populations. Were they only patients in the hospital? It seems that in both of those studies from China, they were hospitalized patients. So there are people who have a different pretest probability of disease. We also don't know the strict criteria that were used for saying that a CT was positive or negative. It seems that they were saying that really any abnormality on CT was interpreted as positive for COVID, whereas, you know, we know that particularly if you're looking at hospitalized patients, a large number of them are going to have CT abnormalities, ground glass nodules, other findings that may be there but aren't necessarily related to the coronavirus diagnosis. So, the opinion of people who've been looking at this and the recommendations now of the RSNA and the CDC and various European societies is that CT should not be used as a screening study in suspected COVID-19 pneumonia, and that PCR really is the gold standard. And I think in most centers, they have reasonable confidence in the ability of a negative PCR to exclude clinically meaningful infection.
And what about CT in the role or in the clinical scenario where the PCR is negative, but the clinical suspicion still remains high? Does CT serve a diagnostic role there, or?
Well, that's the question, is that, if you have a negative viral test, you certainly might want to do a CT to help explain what's wrong with the patient. Why are they having these respiratory symptoms? And then you're doing the CT to look for all of the other things that it could possibly be. Is it a bacterial pneumonia? Is it pulmonary edema? In patients who are receiving chemotherapy, is it some sort of drug reaction or organizing pneumonia? Those are things that you might do a CT in the scenario of a negative PCR study to look for those other findings. But are we going to say, well, there are these findings on CT that despite a negative PCR, we believe suggest that this patient has a COVID-19 pneumonia? I think in those settings, it's a little difficult because you then have to exclude all of the other potential causes of those findings. The CT findings are not entirely specific. And as we noted in our paper on structured reporting, even typical findings can be seen in a wide variety of other processes and diseases. So you might say, okay, in those patients, maybe we're going to repeat our PCR, we're going to quarantine those patients, etc., to make a definitive diagnosis based only on CT findings in the presence of a negative PCR, I don't think is something that many people would do at this point.
Gotcha. The Fleischner Society has recently released some guidelines on how to utilize thoracic imaging in the setting of a suspected COVID diagnosis or even confirmed COVID. How do those guidelines interact with the RSNA consensus statement?
Well, they're really complementary. The Fleischner Society statement is really trying to tell us when we should be doing imaging. And then the RSNA consensus statement is saying, once you've done a CT, how should you evaluate it and interpret and report it? So the Fleischner Society guidelines really are suggesting performance of both chest X-ray and CT in certain scenarios, particularly when testing availability may be limited, that you might go on to a CT in that case to try to either increase or decrease your likelihood of COVID-19 pneumonia. And then once you have done the CT, you can refer to the RSNA consensus statement for interpretation, looking for typical, indeterminate or intermediate or atypical findings, and then using the suggested language for communication of those findings and potential next steps in the evaluation.
Perfect. And with regards to that, what do you think the next steps for CT in the COVID era are with this document in place? How do you think institutions might be implementing the document itself?
Well, I think our intention was really to provide a general framework that one could then take and apply to the particular circumstances, both in your region and in your particular healthcare institution. So you, of course, want to look at what's the prevalence of coronavirus infection in your community. Do you have isolated cases or community spread? If you have community spread, then the pretest probability of infection is much higher, and you're probably going to focus much more on viral testing rather than CT. But if you're in an environment where that viral testing is not immediately available, then performing CT is a reasonable next step. So I think what we're recommending is to take our consensus statement and then bring it to the appropriate people in your institution who are evaluating these patients in your emergency department, in the ICUs, as well as infectious disease and maybe even hospital administration, to talk about the availability of testing and what impact doing CT in patients with either known COVID-19 or with high pretest probability, how is that going to affect your resource utilization, in that it may put your CT scanner out of commission while you're doing cleaning and other procedures in between patients. So best to talk with a group of people who's going to be responsible for caring for these patients and figure out how it's going to be best applied in your situation. And we put some potential options in the document about whether use of the term COVID-19 in a report in a patient, particularly in whom you're seeing findings incidentally, you weren't asked to do the scan to look for findings of coronavirus infection, as well as how it would interact with testing regimens in your institutions.
Great. Obviously, coronavirus, the more we learn about it, the more we realize that it's not a disease that affects one organ system. I've heard a lot of buzz about underlying prothrombotic states, all sorts of microvascular occlusions. Have you noticed anything anecdotally or even in the literature about higher PE rates or other similar thrombotic pathologies?
Yeah, I think a prothrombotic condition is certainly something that's being very widely discussed, particularly in pulmonary, interdisciplinary conferences among intensivists. It's one of our intensivists called me just 2 days ago to discuss this topic. It seems that there are pretty good reports of a much higher incidence of pulmonary vascular thrombosis in these patients. And some reports up to 30% of intubated patients with COVID-19 are showing pulmonary vascular thrombus. And the interesting thing about it is that many of these cases seem to be in the absence of DVT, the traditional source that we look to for pulmonary embolism. And so there's a growing, I don't know that I would call it a consensus yet, but at least questioning about whether that is a potential area where we would want to do more CTs in patients who have known COVID-19 associated pneumonia, when they're having decreased oxygenation or difficulty with ventilation or sudden changes in their status that don't seem to be that don't seem to go along, say, with their chest X-ray findings. Then that might be a situation where we would want to do a pulmonary embolism study to look for pulmonary arterial thrombosis in these patients. Of course, they're also looking at laboratory measures of prothrombotic states, and that's probably going to be something that they'll do first as a screening exam, and perhaps even doing ultrasound of the extremities to look for DVT and reserving CT, pulmonary embolism protocol, for those patients where the diagnosis of venous thromboembolic disease isn't already made.
Excellent, thank you. A question I had was about how you've implemented the standardized reporting system at your institution, more targeted towards advice you could give to providers or institutions out there that are looking to do the same. Were there any hiccups you encountered along the way? And if so, how did you troubleshoot them?
The use of structured reporting was something that we started talking about at Penn very early on in our experience, or even before we had much local experience of planning. And a group of thoracic radiologists, and I think you've spoken with Scott Simpson, he's one of them. On Monday, next Monday, we're going to be having a live event on the RSNA COVID-19 community with discussion with actually all of us from Penn, all 5 of us, myself, Scott Simpson, Eduardo Barbosa, Anna Kalansky, and Maya Galprin will all be available from 12 to 1 to answer your questions. So we started thinking about this quite early on in planning and engaged our emergency department physicians very early on in the process, talking about, are we going to be screening these patients with chest X-ray? Are we going to be screening them with CT based on the Chinese experience? In the end, we decided not to use CT as a screening modality and really use chest X-ray with CT reserved for equivocal cases where it was going to, at that point before we had large-scale testing available, but also where it might determine where in the hospital a patient would go. Would they go to a COVID unit, to a special ICU or not? So, we put together our local reporting language suggestions and got feedback from our emergency medicine colleagues and colleagues in pulmonary medicine about what they would want us to include and how they would want us to try to implement it. I would say, one thing that's different at our institution from reports that I've gotten from many others is that from the beginning, they were telling us, if you think it's COVID, please let us know and put that in the report, even though, we're then going to have to deal with that. If you find something incidentally in a patient who's being examined for another reason and you think it could be COVID pneumonia, we want to know about that. We're okay with putting it in the report, but we'd like you to mention that it could also be other things. And so give us the opportunity to recommend that the patient have testing, to follow up on it. So seeing the words COVID or coronavirus in a report was something that was causing a little bit of fear, but it was always from the perspective of, we don't want people to say, oh, this is definitely COVID-19 pneumonia. But if it's one of the possibilities, of course, we want to know about it. I think at our site, like many others, patients have access to their radiology reports, and you can imagine if a patient is going in for lung cancer surveillance and they see a report an hour or two after the scan is done, which says you might have a coronavirus, that's something that could cause a lot of difficulty and fear for that patient. So it was always important that the structured reporting be a part of an overall communication plan that included direct contact with the referring physicians in cases where findings were discovered incidentally.
Excellent. Optimistically, we're thinking that our social distancing measures are helping and that our overall case numbers are going to start to reduce soon. How do you think that the RSNA consensus statement and the structured reporting suggested by it will continue as the virus prevalence changes in our population?
Well, I think it's one point that I always make when I'm talking with people about this is that we need to make a distinction between someone who has a known coronavirus infection and a patient who has COVID-19 pneumonia. And yes, coronavirus infection is going to increase, albeit more slowly than we had thought it might. But we're going to continue to see an increase in number of people who have the infection. We hope that we're not going to see a dramatic increase in people who have COVID-19 associated pneumonia and that our health systems won't be overwhelmed by that. So in the setting of an increasing percentage of the population with infection, I think having structured reporting is even more important to remind us as we're going in the next months, what are the typical findings of COVID-19 associated pneumonia? And if you see those in a patient, you're going to want to make sure that the patient doesn't have an infection or doesn't have COVID-19 associated pneumonia. Look for those alternative explanations. But on the other hand, even in someone who is known to be infected, if we do a CT and we find atypical findings, then that's going to be useful because it's going to push treatment of that patient to the thing that might actually be causing their symptoms. That is, they could very well have a coronavirus infection, but they have a bacterial pneumonia. And of course, as we're seeing more and more patients with COVID-19 pneumonia, we're going to see more and more superimposed disorders. So, COVID-19 pneumonia plus a superimposed bacterial infection, COVID-19 pneumonia plus ARDS, COVID-19 pneumonia plus lung cancer, or maybe even immunotherapy associated organizing pneumonia. So 2 causes of organizing pneumonia in the same patient. So having structured reporting is going to continue to be very important. And then one of the other things that we made sure to include were tracking codes that one could use to be able to go back and do quality assurance, to look at the epidemiology of the epidemic in a region, but also to do research to try to answer the question, what are the typical findings that you see once you have a much larger population of patients?
Thank you so much, Dr. Litt, for joining us on the podcast. This has been extremely insightful. I really appreciate your time.
Well, thanks very much, and I'm very happy to be here.
Stay safe out there.
Bye-bye.
To all our listeners out there, thank you very much for tuning in. I encourage everyone to take a look at the COVID Expert Consensus document published in the journal. This has been the Radiology Cardiothoracic Imaging Podcast. Please rate, review, and subscribe to us on your podcast application. Stay safe out there, and we will see you next time.